So thank you so much for joining us tonight for our roundtable discussion, the healing journey, amputation considerations with nursing, and it's going to be through the lens of the patient. And we are super excited to be doing this as a part of September Peripheral Artery Disease Awareness Month. So with that, we were lucky enough to put this collaboration together with the American Heart Association. They have the National Action Plan for PAD Awareness, and we have the Society for Vascular Nursing represented. We have the Association for Advancements of Wound Care, and we also have Hanger Medical. And what's really special about this collaboration is we all have near and dear to our heart is improving quality care and patient outcomes. And really what we're looking to do tonight is just take that another depth lower and just like dig into the healing process, which we don't always talk about. We're really good talking about clinical practices, but we're going to dive into the healing component as well tonight. So we're really excited to talk about this with you tonight. And I'll just let you know the format that we're going to follow. We're just going to be really informal. We're really going to just keep all our cameras on. And if we could turn this into a round, we would do a round table. But we're going to just pretend we're in a circle and we're just going to feed off of one another. I have a few talking points that we'll start with, and then we're just going to chat. And I would encourage you to go ahead and put your questions, comments in the chat box. We are not going to keep the Q&A channel open just to keep it fluid, but feel free, drop your questions in the chat. And at this point, I want to thank Mo Malik, who has just been instrumental with Society for Vascular Nursing, orchestrating all the behind the scenes pieces, and she'll come off mute and read some questions just so we can all be engaged. And so we're excited. I'm really excited for you to hear who we have on our panel. And it's really cool that everybody comes from a different, diverse background, similar yet very different backgrounds, and everyone has something unique to bring to the table. So we're going to just kick it off by each of us will talk about like, who are we and what brings us to the table tonight? And while we're doing that, if you feel so inclined, why don't you drop a chat in too? Tell us who you are and what brings you to the table and where are you from? So it'll be fun for us to go back and read that after. I'll start. My name is Nancy Crowell, and I live in Minnesota. And I've had the distinct honor of being a vascular nurse clinician fresh out of right when I graduated from nursing school in 1992. And I'm not going to say that makes me old. I'm going to say that makes me wise. But I was lucky enough to see the evolution, which I will talk and share as we share our stories tonight, but also a holistic nurse. So just the fact that we're going to talk about healing as well excites me. So thank you. And Karen, do you want to go next?
Certainly. I'm super excited to be here. I'm happy and thankful for all of you signing on today. I think we're going to have great discussion. So I'm Karen Bauer. I'm a nurse practitioner. I spent the last 15 years of my career in Toledo, Ohio, where I practiced in a rural setting as well as at a tertiary academic center, post-acute, acute, and ambulatory. So broad practice there. I've been a nurse practitioner for about 20 years, and I am currently now down at Emory University in Atlanta, where I'm the limb salvage or limb preservation program coordinator. So trying to really get in the trenches and see what we can do along the lines of what we're going to talk about tonight. So thanks again for being here, and I will turf it to Leslie.
All right. Well, thank you so much. It's fun to be here tonight. My name is Leslie Green. I'm the Director of Education and Advocacy for Hanger Clinic. I am also a prosthetic user. I am a bilateral below-the-knee amputee. I work with hospitals and rehabs and patients nationwide to make sure that we have access to professional expert content to help individuals find their way from amputation through healing and into full living. My background is social work, therapy, and education, and it's a joy to always partner with all of you in helping frame the patient experience. So let's go over to Laura.
I am Laura Svoboda. I'm with the Association for the Advancement of Wound Care, where I chair the DEI task force. We looked at disparities in peripheral arterial disease, diabetes, and amputation. And I am also on the board of the Save a Leg, Save a Life Foundation, and we're doing a PAD screening in Milwaukee later this week to hopefully intervene sooner. I'll turf it to who's ever next. I don't know.
I think it's me.
There it is.
And it's Murphy's Law that my dog is headbutting her food next to me, being very loud. So I went off camera to give her more food. So my name is Kara Couch. I am a wound care nurse practitioner, have been for 23 years. Grew up with kind of chronic wound limb salvage at Georgetown, and then I had the great privilege of working with the war wounded at Walter Reed, and now I'm at George Washington University Hospital in DC. I also am a past chair of the Scientific and Medical Advisory Committee of the Amputee Coalition, and I still am on the CIMAC as a member, and I'm the current president of the Association for the Advancement of Wound Care. So super thrilled to have this collaboration to talk about the importance of PAD and most importantly, our patients during National Peripheral Arterial Disease Awareness Month. So thank you so much.
Fantastic. Thank you so much, everybody. This is fantastic.
Yeah.
So I'm really excited just to delve into this. And we're going to really unpack that this healing journey is much more than a clinical process. It really is much more of a deeply human experience. And we get to share those thoughts together. And with that, we're going to go to the title and unpack healing journey just a little bit further. I love to bring out this difference between healing and curing. We often don't think about that, but curing actually is eliminating symptoms or getting rid of a disease, whereas, healing may not always be possible, but curing may not always be possible, but healing, which takes place on multiple dimensions, not just physical, but emotional and spiritual, healing is always possible. So when there's that, there's nothing more we can do. Yes, there is something we always can do. So that's really where I get excited and have had the opportunity in the peripheral artery world to work with our prevention clinic and teach folks holistic modalities for stress management to try to eliminate some of the risk factors. And then, of course, through one of our nursing conferences, I met Leslie, and we hit it off as far as her work with amputee support groups. And I have had the distinct privilege of working with her group once a month. I get to share Qigong, breathing, music, shake break with her team. And I'm telling you, with this group and with cardiac rehab groups, pulmonary rehab groups, we talk about these things and we do experientials where folks can actually feel what it's like to have that emotional, spiritual, and psychological healing. Often tears, like, I don't know where this is coming from. It's feeling really good, and I haven't felt this good in a long time. So with that, Leslie, I'm going to pick on you. I'm going to quickly add for the folks here joining. Now, you didn't give yourself enough credit here, so I'm going to boast for you about you just a little bit more. Now, we are talking about tonight, we're having this, nursing considerations from the patient lens, and we have Leslie on here. But know that Leslie is a woman that travels all over the US. Now, I traveled with her once and her phone didn't stop. I mean, she's getting called all the time from folks all over the US, and she's there for them. And so she really brings a wide range of experience and she's the perfect person to represent the patient lens. So we couldn't be more grateful to have you here, Leslie. Could you share your thoughts on the difference between curing and healing? We'll talk much more about it throughout the evening, but testimonials. What are your thoughts, Leslie?
You know what? Thank you. I mean, you humble me greatly, and it really is a privilege to do what I get to do. And I love when you're on every month because you're the first person who really brought this to mind for me, that the difference between curing and healing. And when I think about how healing is that broader, that you're talking about, I thought about it in the time that you decided to convene this group. And I thought, what else does that include? In each one of those areas, the emotional, the psychological, the spiritual, the social, what does that include? And ultimately my reflection led me to say that healing allows patients to find meaning, right? Without healing, I don't find meaning. for this new way of living in the world. I really don't. I feel separate from the world. I don't feel that I belong in it. But when I'm allowed and I'm encouraged to interact with my nurses, and I still end up in the hospital, I rely on you guys to help me find those avenues and find that meaning. You know, we look at patients so often and we all see them who are not having that experience. They are not healing. They're the ones that are isolated. They're not adapting. They're the ones who are rejecting their new reality, their new limb. It's that reintegration to wholeness, right? I mean, you're right. You can't cure what happened to me. You can't put my physical limb back on. But what each one of you do in your role as part of my healing is you support my body image and my identity reconstruction. You are the first individuals. I mean, I see you right after surgery. Your willingness to be part of my healing is the first ring that's going to encourage me to emotionally express and to process the grief that I'm going through. It's the safe space that each one of you create for your patients that allows for that healing. When it comes to the goal setting, you know, when you're shift changing and you're talking about goals, each one of you draw me out of the functional goals and into these more relationship goals, relationships with others and myself, relationships to my anti-fragility and my resilience. I can't speak highly enough of the impact that you have in that healing space, and how your boldness and your willingness to talk about grief and let me know that you see me in all of those spaces lets me know that I belong there still, and you help me find my way back to it.
Mm-hmm. Thank you for sharing that, Leslie. You brought up a really interesting point about, seeing nursing after surgery. I'm going to kind of segue into like the different touch points and opportunities that we have to interact with patients. And I'd love to hear from folks that are like doing the clinical piece, like in the wound care, the transition from critical limb ischemia and limb salvage to now we're talking about amputation. Now, can we talk about that a little bit?
Yeah, so I think I can kind of start that. I think that conversation for us really should start as early as possible. Not that we're doom and gloom and, throwing out that potential, but what I've tried to do clinically is that the minute that the possibility of amputation or palliation, right, or shifting our goal and focus to wound healing, from wound healing to something different, right, something more functional, something where we're living with the wound. The minute that crosses my mind, I take as a cue to have the discussion with the patient. Even if it may seem too early. I don't always do it right then and there. Oftentimes, I'll let that sit a minute because you really have to meet the patient where they are pre-discussion, right? We have to decide what is it in the patient that means healing? Where, what are their spiritual beliefs? What's going on with the family? Where are they in their journey? Some patients will flat out tell you, like, I'm not there and I will not get there. So we have to be really cognizant of that, but I try to, as much as possible, at least have the conversation as early as possible that, hey, look, this could be 6 months, this could be a year, this could be 10 years, this could be never. But here are the 5 different forks in the road that I see in our near future together. And here's how, I want to start the conversation for you and I to navigate them. And I treat it like a fork in the road, to be very honest.
Mm-hmm. How about some of the other folks? You all are touching folks and with the limbs, sorry, with the wounds healing, and tell me some of your experiences, and Kara and Laura, how you manage. Where do you find? I know we have to think about where the patient is in their journey, but some talking points. What are some of your tools that you work with?
For me, I'm always trying to do shared decision making and be honest while also, trying to not be offensive or too doom and gloom, as you say. From our oncology research, we know there's lots of people, the majority of people with cancer, they never even hear the word cancer from their oncologist. They don't even know that they really have cancer, or that their chemotherapy is palliative and not actually curative. And I take that concept and it really translates to PAD and amputation, I think, where people aren't even aware that, that is a potential outcome, and that outcome may not even be a failure or the worst outcome. It just, what does that look like for them, and how would that work out with their life and their goals?
Yeah, I would agree with that. Sorry, Nancy.
No, I was just saying that's a great analogy. Thank you.
Yeah, and I completely agree. And as Karen mentioned earlier, the second you say the A word to a patient, that's like dropping an iron wall. And so it's not something that, is to be used as obviously a scare tactic or anything like that. But it's important to have an honest conversation about, like the forks in the road. And one of the things that I love about wound care so much is that you really get to know your patients, and you have relationships with them for days, weeks, months, years. I have a patient in my practice now who's been my patient for 17 years. And so, you go on this journey with them. And I think that one of the guideposts, or like the touch points that I've had, is that if this is something that we think is, possible to have, giving as much information as the patient needs as early as possible, whether that's meeting with a prosthetist, whether it's meeting someone who's already been through it, is so powerful, because there's life after limb loss. And they really have to understand that like things are going to keep moving on. And some of the patients who've been struggling for years to keep their foot, say if it was from PAD, and if diabetes was involved, they actually physically feel a lot better because they're not on IV antibiotics. And, like there's a lot of kind of shock that comes from that. But I think it's also, we know very well, I don't have a crystal ball. I can't predict when your wound's going to heal, but I can give you a fairly realistic timeline on, now we're going to have the surgery, and then this is what I expect in the next 2 months, in the next 3 months. Like, we will have you in a test socket, hopefully 4 to 6 weeks post-op, depending. And then, we're going to do physical therapy. And that's actually really helpful, because it's not saying like, I'm done with you, move on. Like, my relationship's going to continue with them. And, I want them to keep coming back, and I can actually be a little bit more prescriptive with some roadmaps and things to help them plan their lives, which is the most important thing.
Beautifully said.
I think too that,
Beautifully said.
raises a point. And Leslie, I'd like to hear from you on this too. But one of the things, actually, Kara gives a phenomenal lecture on this. But looking at amputation with the patient not as a failure, it can be a functional improvement.
Absolutely.
Touched
Right?
on that really nicely, Kara.
Yeah.
Thank you.
Yeah, it isn't ablation. It is reconstructive. Historically, I mean, we know this is one of the oldest procedures known to mankind, and we've been doing it for centuries. It's the education piece and it's the healing piece that we're just catching up with now. And Karen, I'm so encouraged by your words on wound care, because we know, the mental health issues with people with chronic wounds, and to hear just how beautifully you care for those patients and provide that leadership in this journey forward, right? And that's what's wonderful. And each one of you have spoken so delicately about how you don't overwhelm the patient with that, but that you do address it, because we are sitting there wondering all of these things. And, we don't want to jump the gun for you either, right? So it's sort of this interesting dance that we all do. And Nancy, as you bring up cancer, I mean, I'm a cancer survivor simultaneously to my amputation, which is what led me down this path, because all of the nurses that I saw in my cancer experience made that such a different reality that I thought, we've got to bring this forward.
Leslie, if you wouldn't mind, you had shared that at our nursing conference when you were a keynote, and you just touching upon, I think a lot of it is just sharing what we know with them so that we're transparent and we have these timelines and they're a part of the decision making. And you had two completely different experiences. You had shared with us that your cancer journey, you had nurses guiding you and educating you, and with your amputation, you were feeling a bit lost. And
Yeah.
so you took it upon yourself to fix that, and,
Right.
and here you are today. But
But look at the difference. Look at the difference 10 years out. As I listen to each one of you, I am just so grateful for having had that experience 10 years to be able to see the vision of what's moving forward now. I mean,
yes,
each one of you are instrumental in making this a care pathway, right? And it is tremendous when I run into patients, and each one of you have spoken about facilities that I get to come into virtually. And I know that that's the reality for your patients. And if that's there, it'll spread. We know that it will.
it was interesting when you were talking about just like the 10 years difference. I see that so firsthand. 1992, when we wouldn't even see our patients anymore. They would go off to orthopedics. And then my last practice, and I'm sure we'll talk more about the interdisciplinary approach and limb salvage clinic. And we had the prosthetics, we had plastics, we had nutrition, we had physical therapy, we had this whole team. We'll talk more about that too, but the evolution is amazing how things have changed. Very powerful. And look at the team there supporting front rows. I mean, you really are the front lines of being there, the voices and listening and being there with their journey. Mo, I see quite a few, we just see like few little chats coming through. Are there any comments or questions at this point? We've talked quite a bit, and we've talked about, the spiritual or the healing component, and just so far, are there any questions that we should talk through from our attendees?
Yeah, I'm not seeing any questions. A couple comments from Lucian. Limb loss is a very emotionally charged situation. The decision is probably never factual, but always emotionally charged. When discussing limb loss with my patients, I bring up the example of the double amputee, Amy Purdy, that was a competitor on Dancing with the Stars.
Oh, yeah. Very cool. Yeah. Thank you for the comments. This is great. We love having your engagement, and feel free if there's something that you want us to explore a little further. That's what we're here for. We want to just talk through this with you. I think one of the things that we started talking about, I'd love to talk about, we'll have a few things, but the interdisciplinary approach, what does that look like at your centers?
So I'll start again, just that moment of silence. I think it's different for every center, right? It's there isn't a right or a wrong when we look at multidisciplinary care, but I think it's important to distinguish between multidisciplinary care and interdisciplinary care. Because you can have multiple practitioners seeing a patient, but if you're not all on the same page and having the conversation together and centered on the patient's needs, you are not interdisciplinary. So I think at our centers, that's what we have aimed for, is that whoever is on that patient's team, if it's a diabetic foot ulcer, osteomyelitis, I'm generally going to have infectious disease, vascular surgery, wound care, right? If it's more of a CLTI ischemia patient, we're going to maybe have vascular surgery, endocrinology. You have different care people, but I think the key there is making sure that we keep it patient centric and that we are truly having discussion with the patient, not about or around the patient, in front of the patient. So I think when I think multidisciplinary care, that's what comes to mind. But secondarily, one of the things that Kara, you might be able to speak to too, that we just worked with a physical med and rehab physician talking about prehab, right? And making sure that we're involving all of the necessary specialists, but especially the prosthetists prior to amputation, so that patients can have those resources and see what life is like, afterwards. So I think that's another key component.
Yeah, I would agree. I mean, I think that again, we try and also get a preoperative, if we come to the decision that this is what needs to happen, a preoperative physical therapy evaluation even if it's the day before surgery, because it just helps to get some baseline information on the patient. And one thing that I want to point out, we haven't really touched on it yet, but we have shifted from when I started doing this, 23, 24 years ago to, whatever length of the foot is like better. And now we are moving more towards what is going to actually be functional for the patient. Because if we keep, like part of their foot, but they can't actually use the foot, is that helping them? And I would argue that it really isn't. And so there's much more of a shift towards doing either a transmetatarsal amputation or transtibial amputation or transfemoral. But I mean, I think the main goal is to try and get back to a level of function that allows the patient to participate in their life. And, it may not be exactly where they want it to be immediately, but that's why, again, having these interdisciplinary teams is so important, because when you have the prosthetist there, in the clinics, when you have physical therapy in the clinics, when you have the rehab doctors in the clinics seeing these patients, yes, some patients can be like an Amy Purdy where they go on to compete in Dancing with the Stars or they go to the Paralympics. That's not the reality for the vast majority of our patients, but it doesn't mean that they can't get back into doing, going out like with their families on the weekends, going to malls, going to whatever. And there may be certain instances where they can perform at a higher level than maybe what their day to day is, but they can save up that energy envelope for those experiences so that they still are not just being in life, like they're not just surviving, they're thriving again. And that's what I think is so key.
I think you bring up a good point, Kara, that we often look at the Paralympics or the superstars, but we forget that even they have average lives. They go to the mailbox, they walk down the street, they walk the dog, they make the bed, they do the laundry. I mean, for some reason we are fixated on the fact that they're out there dancing or skiing or whatever, but we forget that they make macaroni and cheese and live an average life, right? And I think, like you said, most of the people want to hold their partner's hand and go for a walk or keep their children safe if they're playing in the yard, if the ball rolls into the street. I mean, these are things that are everyday things. And I have to say, when it comes to collaboration, Karen, kudos to you for calling out the difference between the two. But I'll tell you the one thing that when I read this that I really reflected on, and where is the glue? And I'm not just glad handing you guys really are the glue. The nurses are always the glue. I mean, it's the truth. But I think when I think about collaboration, what are things that I would want to see as a patient with a collaborative team? I'd want to see shared goals between all the disciplines, right? So often we get this group wants this and this group wants this that doesn't quite match with that. Or we get the hierarchy of who is the more important player on the collaborative team, right? So I would want to, really a mutual shared level of respect of practices and their importance at some point in my journey, I think is really what frames collaborative teams, whether interdisciplinary or interdisciplinary. That's got to be the same because it comes off to the patient. But what always comes off, I'm not kidding you guys, you're our glue. You really are our glue. I think there's one more piece. I think that we oftentimes go to a peer visitor too early. And they're the yay, rah, rah people who sometimes set a patient up for failure. I think we need to understand that there's a role for an educator in there that doesn't come in and yay, rah, rah, and promise the sun, the moon, and the stars, but says, you know what? Let me connect you to the ADA. Let me meet with you. So maybe, Karen, this goes to that wound care time, where we start to gently have conversations about, what are some of the resources that would make life easier as we keep going down this road that has forks in it, and introducing a new role to it that, selfishly I get to do. I meet with patients 4 or 5 times before surgery and we go soup to nuts, and none of it is the yay, rah, rah, you're going to ski or dance or run. It is the reality of, move your favorite foods to the middle shelves in your refrigerator and don't plan on taking a shower at home the first month. Stay, the really practical pieces. Collaboration has got to widen that circle out to be effective, I think.
Leslie, I think you just brought up a really important piece that I'm just thinking of. It's been 4 years since I was in um, vascular practice, but just thinking of how ideal it would have been just to have those pieces of information and encouragement that we can talk about what the post-op plan looks like and pain management and therapy, but you just said a lot of things that I wouldn't have ever even thought of, just about moving your food to the shelf and just things like that. And we will talk more about this, so let's not forget, but I want to come back to this because we're on a roll here, so let's keep it going. But I want to talk about resources for amputees and that we can share with our members when we're in clinic. I know what it's like. We get to be there right front and center, but we also have like this whole list of a whole clinic full of patients, and the timeline is there, and I wish that it wasn't a factor, but I remember it being a factor, and I wished I could have just had one patient for the day. I got to talk with them on the telephone quite often, but I want to talk about resources. But I want to say two things. When you were talking, Kara, one of my members that was just speaking about, healing, she was in her 80s and had an amputation, and she was just devastated because she was a big Minnesota Twins fan and just felt like that was over. And I will always remember her sending, her daughter sent a picture of her back at the game. And that was her win. That's her healing. She was back she didn't mean that she couldn't go to the Twins game. So things simple as that. I had another woman that was really going through a tough time. So what are some of the things that make you want to get up in the morning? And without hesitation, my grandchildren. So let's make up a care plan and let's incorporate your grandchildren into your care plan. Yes, you have your medications, but let's open up the deck and breathe in that air and get pictures of your grandkids and music, aromatherapy. So just lots of tools that we can use to kind of uplift. So thank you. Does anyone have anything to say before we go to Mo to see if I thought I saw a question coming up. Did anyone else have comments?
Well, there was a comment, which is, are any of you really rural? If so, what does interdisciplinary look like in that situation? And I would consider myself fairly rural. So I'm in a wound and vascular center up in Sheboygan, Wisconsin, and we get people, coming in from several hours away to the clinic. And I agree, that is an incredible challenge. And that's what I advocate for quite commonly, is that people in academic medical centers have this like luxurious team of really intelligent people and all these wonderful resources. But when you're in the middle of Sheboygan, it's upon the clinician to really reach out and find like what is actually available to people. And I just took a drive today, driving through a nearby, even smaller town, and it was an incredibly aged population. Our rural population is aging rapidly, and we don't have the care providers, the nurses, to take care of them. So, what does that look like when our telehealth regulations are supposedly going away in 2 weeks? How can we provide these resources, this care, these beautiful personal discussions you're having with people if we can't even get to them and talk to them? So I don't know what the answer is, but the rural piece is definitely a whole nother difficult setting.
Piggyback on that, Laura, last year our roundtable was that topic, rural disparities with PAD, and it was fantastic conversation. That one example I want to pull out was when I moved here. I lived in the cities and then moved to a rural town, and I saw that there was a vascular surgeon at this hospital and I was like, I've got to meet her. I mean, like, how do you do that as, a female lone vascular surgeon? And I went out on a limb and reached out to her to see if she wanted to participate. And she said yes. And she joined us and had some really interesting insights and how that her role, you really have to partner. So she partners with orthopedics a lot, podiatry a lot. She trains and she works in the smaller rural hospital, but also makes a point to go to the larger city hospital to keep her skills up. And also just considerations like there's an emergency situation, critical limb ischemia, and the roads aren't plowed. So these are real things. So you're right. It's a big deal, and we could probably do another conversation about this next year because things are always changing. But great question and comments. Thank you.
You know,
I think
looking at the, oh, sorry, I was just going to comment on the virtual piece, and I think that's what makes me so sad is that we are returning populations back to a scarcity model by eliminating the telehealth, and we know better than that. You know, we've existed in that, and people who go through amputation already operate in that. Even if you take away the telehealth, you know, think of 10 years ago before telehealth, when you consider PMR, there are not enough PMR providers nationwide, nor will there be with the projected amputations that are coming by 2030. It's a staggering Chicken Little. The sky is actually going to start falling, and we're removing services that are critical to the health and care of individuals living with limb loss. So looking at some of those deadline dates, it is terrifying to think that the one way that we have learned to be part of healing is virtual, and we're removing it. It makes me go, why are we doing this?
Yeah, it's not great. I did put in the chat just for people to know that if you are not in a luxurious urban environment, as Laura said, that the National Limb Loss Resource Center, I linked to the Amputee Coalition, like they have so much stuff. And one thing that they do try to do, I'm not saying this is perfect, but I forgot who mentioned it, maybe Leslie. If you're going to have an amputee peer visitor or certified peer visitor, they try and match people, so you don't have someone come in and be like, rah rah, life is going to be amazing. Life's not amazing. I mean, it really kind of sucks quite a bit when you're going through it, and there's a whole grieving process, and much less like getting used to your new normal as you move on your journey. But I think there's a lot that can be done, and if you are in a rural environment, there are navigators and people there that can help. So because we're all busy, we're treating patients, we're doing our best, but there are other people that can help guide them through and figure out and help battle the insurance companies, when they won't pay for a piece of their prosthetic device and all of the other nonsense that our patients have to go through to just live. So, just putting that out there.
But even that, Kara, thinking about the funding sources for the National Limb Loss Resource Center being cut.
Oh, I'm well aware.
Yep. Mm-hmm.
Yeah, it was a huge battle because they were cutting the oh my gosh, the Center for I'm going to mess up the overall name, but the Center for Living or something. I'm messing up the over name.
Centers for Independent Living. Yeah.
Yes, even with that, but it's not just limb loss. It's all the resources for rural health and like everything else. Like it's just it's a travesty. Anyway,
yeah,
we can move on, or we can keep talking about it. It's up to you guys.
I feel like there's a lot to unpack. So if there's more comments, feel free. We are not on any set. I think this is a timely, that's what I love about this. This is timely. So what do we do? Where are our resources? Where can we go to try to help? So
yeah, and we're in a unique period of time right now. And I think as healthcare providers, we've gone through a lot as well. And so the change is even more than ever. And not only that, our patients are going through that as well. And so this is just another complication, more stress, more difficulty, less resources, less access. And it's amplifying the burnout of healthcare providers,
right?
Because we're desperate to help people. We don't have enough time. We're not getting reimbursed, and we're getting moral distress and burnout wanting to help and not being able to.
Yeah. I think that's where we say too, like, especially in the rural environment, I always think of it as like everything and the kitchen sink. The way that I see it is every single resource that I can leverage, I try to leverage, be it phoning a friend in addition to the amputee coalition, in addition to the local support group. Like I tell patients, I'd rather cast a wide net and put unneeded resources in front of you than deny anything, because I feel like even for us, we need all of those resources.
Yeah.
So even the smallest of resources can turn out to be really monumental.
Getting back to interdisciplinary care and access, though, when you're in that rural setting, you may only have one vascular surgeon, and that is the only person that the patient can access. And then I don't know what the answer is, but what do you do if, if they need more or something different, or, it's just, it's a
Maybe we
solution
need
I'm
to
not sure of.
we
Mhm.
need to like leverage a national hotline for people like us, where
Mhm.
when you're in a rural situation, you can call a national hotline and get some sort of resource, some sort of something,
Mhm.
like phone a vascular surgeon, phone a friend. You get somebody
Not a bad idea.
That's awesome. I feel like I was on a panel with Society for Vascular Surgery where they were talking about that. That was a few years ago. But there was some discussion of like a national hotline, phone a friend, like the bat line to get some support. I mean, it's a great idea.
I think that that's one thing that we in wound care are really good at doing. One of the challenges I see with the vascular surgeons that I've worked with over the years is they feel like they have failed the patient. And that, like if fine, like we'll do the amputation, like, they're just it depresses them quite a bit that they, have been putting in like time and energy and things. But another point is it really does matter tremendously who the surgeon is, because if that amputation isn't done right, that person's never going to wear a socket. They're never
Right.
going to be an ambulator. Like you're setting them up for a wheelchair life, which is also a tragedy. So like I can't tell you how many where like the surgeon that I trained with is phenomenal. He's a plastic surgeon. And we would treat people where he was trying to do their redos and trying to fix what wasn't done right from the beginning. So one thing that would be helpful is like empowering the patient to ask the questions. How often have you done this? Like, like what's your outcomes? Like the patient should be informed and be able to, I would, some people aren't going to take that well, from a surgeon. Like some surgeons are going to be offended by that, which is also a tragedy if that's the only person that they have like as their person that can help them. But, it is really, really important that it gets done properly for the patient.
Well, you bring up a really good point, because I know there was a time prior to my amputations when prosthetists were involved in the operating room who were advising on closures and lengths of limbs. And I guess and this is not for this discussion, but since we know that the number of amputations is set to almost double by 2030, looking at, will there ever be a certification for amputation? Will there ever be an area of training, or maybe there is and I just don't know it, that is beyond just the mentorship that appears to be how that's taught? Will we ever come and do a standard of care, understanding that causality for amputation can widely vary, but since we're not involving the prosthetist in the operating room the way that they had been, how do we make your point less prevalent in terms of limb? That's something that I've often thought about.
That's an incredible idea. What is the standard of care for post-amputation recovery? And I always, again, I'm like a Debbie Downer. I'm like, but what's reality? But it's good to outline what that standard, those best practices is, so that we know we can, get as close as we can. And we also use that to advocate from insurance coverages and things like that when we have those evidence-based recommendations. So I think that's a fantastic idea.
Yeah. Right.
That really is. And just having involved in, do you guys have prosthetists involved in like the consults in your clinic? well, as a transitioning from, you know, limb salvage to amputee, is that part of the team in your organizations?
Yes.
Yes.
For our Yeah, we
Yeah.
work with a couple of different prosthetist groups, and I'm really lucky that one of them's office is about a block away from the hospital, so they can come over and do, introductions and just because I say the prosthetist is going to be the second most important person in your speed dial besides like your mom or your spouse, and and one of our prosthetists is also an amputee, which is very helpful because he doesn't advertise that. He walks in, he sits down and then he pulls his pant leg up and they're like, whoa. That's not often that, sometimes that is the case, but I think that it really does matter. And there was the chief of PM&R at Penn State, Karen and Laura got to meet him this past week at a different meeting we were at, and he has a really great outline for like the shared decision-making model. I'll try and drop the article in the chat for everybody that talks about, again, like here's the timeline and like these are the things and these are the people, and it really is a practical way to kind of look at it for everybody.
I see a comment in the chat here. That's a spicy question of who do you guys think is the best specialty to perform amputations? And the listed options are ortho, vascular, general surgery, or plastic surgery. So I know my answer, and it's actually not even listed here. I would say podiatry. The new podiatric surgeons are doing a really good job with functional amputations. So giving, doing Achilles lengthenings and things like that. So they're the ones that do that most routinely that I've seen by me.
I'm totally spoiled and biased because I've worked with some phenomenal surgeons in orthovascular and plastic surgery. I don't have many patients of mine that their amps were done by general surgery. I think the key thing is, like I said, doing the myodesis and, and connecting the muscle to the bone, and doing those important steps, because if you just do a guillotine amp and then sew things back together, that's a floppy distal residual limb. Like nobody can do anything with that. So it's having those components taught to people to do it properly, and really make a difference. And honestly, a newer specialization, I should say, which is fortunately becoming more popular, is doing a targeted muscle reintervention at the same time as the amputation, which helps decrease, hopefully for the patient, their postoperative pain issues and challenges with that. And that is primarily a plastic surgery technique. I think some orthopedics do it, but I know that plastic surgeons in my hospital are starting to do it. At Georgetown across town, they do it routinely. Like that's like normal for them. But they, again, you have to have specialized training in that. But that's another kind of game changer thing. So I don't believe vascular or ortho or gen surge are there yet, I should say.
Yeah.
And mine were done orthopedic. One was orthopedic. My first was done orthopedic with plastics, and it's a beautiful limb. And my second was done just orthopedics, and there's redundant tissue.
Yeah.
Which has
It's
become
a huge
an
issue.
issue. But I think the reason that I would like plastics and ortho to combine is looking at technology and prosthetics and looking at some of the procedures. Of course, the RPNI and the TMR, but also the AMI. How are we preparing patients to potentially wear some of these advanced units so that as we have the technology move forward to being able to weight bear through them? I think about MIT and what they're doing with the AMI procedure and the agonist antagonist muscle beds, allowing people to be prepared for higher level technology and prosthetics moving forward. So again, we talk about interdisciplinary teams. I think we really, like you said, we need to look at the functionality of the person and what will they be eligible for and who is the best person to do it, not just who generally does it, right? But that means that we're educating the patient on technologies before amputation and exposing them to the potentiality of returning to function or higher level function.
I think some of the things that you've been talking about, Leslie, I mean, all of you, gosh, it would be really nice. So if I'm just putting myself, the lens of the patient. If I'm learning that this is going to be a part of my future, I'm probably going to be on Google, and I'm probably going to be learning at what things do I need to know. I just love that you brought up some really important considerations that they don't know to ask those questions. So is that a part of conversations that we're having with folks
We,
facing?
we should be. I mean, Karen, you brought up the point of you don't want to get in too early, but as a patient, I'm going to say, understood. Nobody wants to face the emotional reality, but whether you educate me or not early on, I'm still going to spin in the anxiety that I know deep in my heart where this is going. Even if we're not addressing the elephant in the room, I remember talking to the individual who I was receiving care from and saying, am I going to lose this leg? And they didn't want to talk about it. I initiated it because that would have given me time to prepare. Now, granted, I'm an old social worker and therapist and educator. I'm going to get in there. I was in there with my cancer. I'm going to dig in. But if we can agree that the way we're educating joint replacement patients, we need to be educating individuals who have limb salvage, potentiality for limb loss, and allowing them to make an educated decision, not an emotional decision. Because many times the decision is made based on I want to save my foot at all costs, even if it's not going to function. And we've got to start being honest about that. And God bless the surgeon who's willing to do both surgeries. I can't ever express enough gratitude. I can't imagine what it is to be in an operating room in their position or your positions and stand there and decide the fate of this person in a minute. Right? I was dying with sepsis. I can't imagine what it was to remove my limb and stand there and hold it while everyone around watched. What you undergo for us needs to be acknowledged, but we all have to come to a place where we say, we need to put the emotions aside so there's a future that lay ahead. Right?
That's a really
One
great.
point. Sorry, Karen. Go ahead.
Go ahead.
I just was going to make an additional point, talking about like the emotions and everything. We haven't brought up the stress on the caregivers, and also like that their grieving journey and what they go through as, adjusting to, because their lives are changed, as well, just as much. There are additional resources in the Amputee Coalition thing that I put in there, but I just didn't want to be remiss and not make that point that that's a partner. And, sometimes that's a person that, when you have the patient that I'm going to save my foot at all costs, but their caregiver is like, this is not happening. Like, this is not feasible. We have to have a discussion. So, and attending to the souls of the caregivers as well as the souls of the patients, I think is also critically important.
Amen.
Hugely important.
Yeah.
Agreed. That actually is a part of my role now as a case manager, is a lot of resources for caregivers. And I am going to just say boldly, and I transformed from my life working in the clinic to where I am now with an insurance company, that there are case managers that are available. And that's my job, is to help navigate through these sticky pieces. If there's a denial, why is it denied? Is it simply because the right records weren't? And I'll tell you what, I've totally changed my tunes. I used to go nuts over the denials, but a lot of it, guys, is because we don't have the right diagnosis or the right medical records, and we can fix it like that. So tap into your resources. Insurance companies, if they have case managers and they're doing their job, they're there to provide resources to folks who need support, and that's caregivers as well. So
Yeah. So there's a comment that I think is timely with that. I think two things. One, going back to which service is better to do the amputation, I will say, just as a tip, we always get a second, not always, if we have the time and the ability, we get a second opinion. So we're vascular surgery, right? We'll have ortho or podiatry if the patient has a podiatrist that they've established a relationship with, or if it's been foot and ankle orthopedics. And we establish that relationship with those services so that we can send patients and they can have the discussion from a different lens. But we always encourage patients to get a second opinion, whether that be via who we send them to and who they have a relationship with or otherwise. But there's a really good comment too, kind of to the multidisciplinary and ortho and plastics and stuff, that I think ALPS and the other teams, SVN, AWC, need to figure out how to improve awareness of specialists within specialties. ALPS is moving toward accreditation for programs as centers of excellence. This has been an ongoing discussion within our field and within wound care as far as kind of certifying, right, or coming up with the standard of care. So as we've been talking tonight, I feel like we do need some sort of a white paper around this. But I really appreciate forums like this, because I think that's a really salient point that, you know, we're all working in these silos of, you know, this organization focuses on this specialty and this organization focuses on this specialty and this organization is led by these people. Whereas if we come together, we really can start to look at what this truly looks like from all lenses, right? But keeping it around the patient. So I think that's a really good point in the chat there.
That's my cat food going off. That means that we have 5 minutes remaining.
I was just gonna say, we're at that. How did this go so fast? We have 5 minutes. We can take any questions if you have them. We can close and give you 5 minutes back, but I feel like we've really covered a lot of amazing conversation. I mean, I like what you're saying, Karen, like it just feels like there is potential. Like I would love to see, I'm just learning so much just even from you since I've been away, and it's only been 5 years. I mean, so it just is really interesting that we have the knowledge, but it's the patients facing it that really should have it in their hands. So I think that that's something that a little take home that we could maybe build upon. Is there any other questions in the chat? Otherwise,
Nancy, one other I saw, are mortality and morbidity rates after amputations rising or falling, and what are the biggest contributing factors to either answer?
I can tell you that a huge contributing factor to morbidity and mortality is not getting the patient up and moving. So, you know, if we can get them back to some level of function, and getting their cardiac output, I mean, for every like level amputation that you go up, morbidity and mortality rates go up because of just the sheer amount of cardiac stress that the patients have. So an above knee amputee who's bilateral, it's like 200% more stress on their cardiac system. But if we can get the patients, you know, using a walker while ambulating, something, sitting in the chairs is really a key driver of those M&M rates.
And to be able to ambulate, you need to have prosthesis. So I
Right.
would like to use this platform to advocate for what I saw in Gaza last year, which were children, new amputees with no prosthesis. And they're still not allowing prosthetic devices, even 3D printers and things in. So these new amputees are still without prosthesis. And that's certainly going to be contributing to, along with nutrition, a lack of rehab, you know, to the morbidity and mortality rates of just not being able to move and get that cardiovascular fitness back.
Yeah. Let alone the time to fit, you know, for those children and their mental health, right? I think the one comment that struck me and that I would love to say, pick me, is we'd love to get some of this in with residents. My ultimate goal, like I said, having been part of cancer and knowing how much my cancer team knew about my experience, and I think about Susan G. Komen and Estee Lauder and Betty Ford and all that it took to change the patient experience. My dream someday is to have a course with residents where we talk about the patient experience and what needs to be meted out for them early on, mental health, you know, education, resources, all of that. I know that it's going to take getting in at the ground level early on to really shift this paradigm, but we have to be willing to do it. Again, I don't mean to be Chicken Little saying the sky is falling, but we are looking at 2030. And are we prepared for what we know is coming due to diabetes and vascular issues? I'm in a position that we're not, and that this conversation hopefully gets broadcast. And like I said, pick me. I'd love to be a patient advocate going in and helping teach residents what the patient experience is and what it can become.
fantastic. And that was a fantastic way to land this. And I think that we've covered beautifully demonstrating that, you know, the healing journey is much more than clinical outcomes, and it really touches upon the healing that goes along on all dimensions, and really that there's a shared commitment that we see and hear and honor where they are in their journey. And nurses really do. We have the opportunity, you know, it's like the thread that weaves together compassion, commitment, and advocacy, and, you know, really to transform lives as well as outcomes. So I just want to thank you all for joining us. Best wishes. What a fantastic group of panelists that we've had here tonight. Thank you, everybody. Peace.
Thank you.
Take care.